Welcome back and good evening to each and everybody. This is our teleconferencing program and this is our fourth and second last session of today's program. In this particular session, we'll talk about pyelouretric junction obstruction, and our expert of this session is Dr. Satish Agrawal. Dr. Agrawal is a professor of pediatric surgery and unit head in Maulana Azad Medical College, New Delhi, and we also have with us Dr. T.K. Jana from School of Health Sciences, Indira Gandhi National Open University. To ask any query about pelvic ureteric junction obstructions, you can use our phone lines. The numbers are 011 2953 2844 and 2953 2845. We have one toll free number also, that is 1800112345. To download the forms of National Board of Examination, you can visit our website. The website is www.netboard.edu.in. I spell out www.netboard.edu.in, and you can use this website for other purposes also. DNB candidates can apply for CME workshops for DNB theory, practical, clinical thesis protocol writing, and DNB consultants also apply for CME workshops. And there is also a counseling session for those candidates who have failed in DNB examinations by downloading the forms of from a National Board of Examinations website. The candidates who have anything for publishing, they can give it for publication also. And to get the DVDs of teleconferencing programs, you can contact National Board of Examination. I would like to tell you that this teleconferencing program is jointly conducted by Indira Gandhi National Open University and National Board of Examination. And now I would like to request Dr. Satish Agrawal to start this particular session about pelvic ureteric junction obstruction. Dr. Agrawal, please.
Thank you, madam. At the outset, I must thank you that you have invited me for this talk. Now, the talk will be in two parts. The first part will deal with the etiopathology, clinical features and diagnosis of PUJ obstruction, and the second talk will be about the operative management. Feel free to ask questions, and it should be more of an interactive session rather than a didactic lecture. PUJ obstruction is an entity which is not only important from your clinical and operative point of view, but also it is very important topic for your exams, and therefore you must try to know whatever you can for this topic. It is very likely that you will get a long case of a renal mass, which will be a hydronephrotic kidney, and the most important diagnosis in that scenario is PUJ obstruction. And therefore, it is a very important topic. Now, just few figures which you may like to remember. That it's fairly common condition with almost equal ratio for male and female, although the left side is involved at least twice as common as the right side. Mostly it is sporadic, but there have been reported cases of familial inheritance. An important thing to remember is that if you have some other renal anomaly, say for example a multicystic dysplastic kidney on one side, or one or other components of vectoral association, then you must actively look for a PUJ obstruction, and therefore these are the candidates where you will have a high degree of suspicion and you will do investigations to find out or to exclude a PUJ obstruction in these situations. That's a very important slide because there are several causes which come to mind when you are dealing with a PUJ obstruction. Say for example in adults, an obstruction can be because of a stone, but PUJ obstruction, when we talk about, in 70% of the situations we are talking about an intrinsic obstruction in the upper part of the ureter and the pyelouretric junction. Therefore, it is an inherent disease of the upper ureter, where it joins the renal pelvis. So renal pelvis per se is normal. It's the junction where the upper ureter starts that there is a problem in the muscle, which is usually hypoplastic and very often replaced by disorganized fibrous tissue. And it is almost never a total obstruction. For example, if you were to pass a double J stent from below, it would go into the pelvis. It will not get obstructed by a total obstruction. Similarly, while doing an operation, you can still pass a feeding tube down the PUJ into the ureter. So doing that phenomenon or doing that exercise does not mean that there is no PUJ obstruction. Remember, PUJ obstruction is a functional obstruction, never a total obstruction. The another important thing to remember is that the upper ureter which is involved can vary in the length. For example, it may be involved only for a short distance, if 0.5 centimeters, 1 centimeters. Often it is about 2 to 3 centimeters, but in situations it can even extend up to 8 centimeters. So you really have to know that the upper ureter is at fault, and the length for which it is at fault can vary from 1 to 8 centimeters. Other reported causes in this sequence of causes is ureteric folds. Sometimes you will see a very typical appearance in IVPs or other investigations that the upper ureter is folded in itself, but there is no obstruction. The dye is still flowing down. Usually it's a self-limiting condition, does not cause mechanical obstruction and does not warrant a treatment. Only rarely will it lead to a persistent obstruction which may require surgical management. Another phenomenon which is often quoted in books is high insertion of ureter. Now it is doubtful whether it's actually the cause of obstruction or the effect of obstruction. Now you can imagine, if the pyelouretric junction is obstructed, then the pelvis will dilate, and if it dilates, it has to occupy some space. So the portion of pelvis which dilates below the pyelouretric junction obstruction will appear in due passage of time as if the ureter is actually inserted high, while actually it may be just the effect of the PUJ obstruction that it appears that the ureter is inserted high. So it's just a morphological variation in the findings, and mostly you will find such a finding when there is a gross hydronephrosis, when the pelvis is really massively dilated. One more condition is extrinsic obstruction by lower polar aberrant vessels. This is also an important cause. Most examiners are keen to ask about it. Again, there is a doubt whether an aberrant vessel really causes pyelouretric junction obstruction or not. Sometimes it is just a finding. Mostly the group of patients that are affected with a lower polar vessel are older children who present to you with pain. So they had nothing wrong during their initial childhood, but at the age of 9 years, 8 years, 10 years, they start complaining of pain. You investigate, they have hydronephrosis, you diagnose them as PUJ obstruction, operate on them, and about 30 to 40% of the times you will find a lower polar vessel which is causing some problem. Sometimes it is an actual cause of obstruction, and with experience you get to know that whether this vessel is causing obstruction or not, and if it is, then the treatment is that you do the anastomosis in front of the vessel. So just to recapitulate, this is a diagrammatic representation. The most common form is an intrinsic obstruction of the upper ureter and the pyelouretric junction. Second is a high insertion of ureter, and third is a lower polar aberrant vessel. So these three are the important things to remember. And as I mentioned, length of this disease segment may vary. This is an important point to remember. So lower polar vessel. Figure-wise, about 5% of all hydronephrosis which is diagnosed antenatally and going to pyeloplasty will have an aberrant lower polar vessel. And this figure goes up to 30% in older children. So 30% of our older children pyeloplasties, you will find a lower polar aberrant vessel. And again, it is important to remember that the vessel may be there, but it is not necessary that it should be obstructing. There could still be a coexistent intrinsic obstruction. So, primary goal should be to relieve the intrinsic obstruction. So, you cannot say that the ureter is normal, pelvis is normal, it's only the vessel which is the cause of problem. So, you still have to look for the morphology of the upper ureter. You still have to trim the pelvis. It's just that if you feel the vessel is obstructing by that morphology in that area, then you place the anastomosis either anterior or posterior to the vessel, depending on where the vessel is. If the vessel is interior and you think it is obstructing, then you place the anastomosis anterior to the vessel, or vice versa. Now, there are certain PUJ variants which sometimes are asked in exam, and it's important to know them. One is secondary PUJ, secondary to vesico-ureteric reflux. Reflux patient can have repeated UTIs. Repeated UTIs can lead to scarring in the pelvic-ureteric junction obstruction and can lead to a secondary PUJ obstruction. Retrocaval ureter. This is a rare entity, and this can cause obstruction into the upper ureter because of compression between the inferior vena cava and the vertebral column. And this usually results from an abnormal development of posterior cardinal vein. Now, posterior cardinal vein is the one which develops into inferior vena cava, and anything going wrong there can mean that the ureter can go behind the vena cava and then hook up and come anterior. Another thing is an intraluminal obstruction. Very rarely you can have a polyp in the mid-ureter. Normally it's in the mid-ureter. So there is no intrinsic obstruction, but it is an obstruction to the mid-ureter because of an intraluminal object. And there are some special situations in horseshoe kidney, and again PUJ with VUJ can also occur. Now, PUJ with VUR is an entity which sometimes is asked and sometimes can fox you because the management is a little bit different. Just easy to remember, 5% of all PUJ obstructions will have VUR. Now, they can have coexistence in three different ways. One is they simply coexist. So, there is a problem at the vesico-ureteric junction and there is a problem at pelvic-ureteric junction. Both have some problem, PUJ obstruction and reflux at the lower end, and they are coexisting. Second scenario is where the reflux is the primary problem and PUJ is a sequelae of infections induced fibrosis. So, that is what we dealt with as secondary PUJ obstruction. The third scenario is again reflux is primary problem, but PUJ is there and it is functional. Just because every time ureter gets transported back into the pelvis and the pelvis has to send it back to the bladder, so there is a high transportation load on the pelvic-ureteric junction and it can't cope with it, and therefore there is a functional obstruction. Now, what are the investigations? I hope everything is clear until this point of time. If you have questions, yes?
Sir, if a mother comes to us,
Mike?
if a lady comes to us who is a mother and says that ultrasound shows a PUJ in her child, unborn child, so how do we counsel her?
Right. The problem of antenatal diagnosis is a real issue in today's world because maternal ultrasound or expectant mothers do get an ultrasound, and hydronephrosis is a very common finding on antenatal ultrasounds. So yes, that is a problem. But in such cases, when the mothers or expectant mothers come to you for counseling, you have a careful look at the ultrasound and look for what are the descriptions on the ultrasound. For example, is it a unilateral hydronephrosis or bilateral hydronephrosis? Are the ureters also dilated or not? And most important, antenatal ultrasound, is the bladder emptying? Is the bladder consistently full? Or if there is oligohydramnios, because the liquor forms from the fetal urine. If liquor is adequate, then you don't have to worry, because that means the fetus is passing adequate urine contributing to the volume of the liquor. If there is oligohydramnios, then you have to carefully look for a bilateral problem. Distended bladder, say for example valves. Valves is a more serious problem. than hydronephrosis. By and large, because we are dealing with PUJ obstruction, and PUJ obstruction antenatally will present as fetal hydronephrosis, usually unilateral, occasionally bilateral, without any signs of bladder outlet obstruction and with normal liquor. Okay. In those situations, there is no need to worry. Certainly, it is never an indication for termination. Okay. Third thing, you have to counsel the parents that the child may have or may not have a problem in the kidney. Many a time, in fact, 60 to 70% of the times, antenatally diagnosed hydronephrosis does not require any surgical management. So, to reassure them, and if it does require management, it can be managed very easily by a postnatal approach. So, there is no need to worry. The pregnancy should carry to term. The delivery has to take like a normal delivery. There is no special precaution for delivery. And so that is how you will counsel for plain simple hydronephrosis, not associated with oligohydramnios. Okay. So investigations. To diagnose PUJ obstruction, this is the list of investigations that you have to do. Of course, apart from this, there are blood investigations, routine investigations. So the mainstay is an ultrasound. Ultrasound, then isotope diuretic renography, usually done by a DTPA. There are recent more expensive reagents like MAG3, but DTPA is still a most commonly used radioisotope. Intravenous pyelogram, MCUG, and occasionally DMSA. DMSA is not a primary investigation. Whenever you are dealing with obstruction, you ask for a DTPA scan. So this is the list of investigations. Ultrasound is the most important investigation of all of them. It must be an initial study. Initial study, when you do an ultrasound, please inform the radiologist what information you want. It should be done by especially a pediatric radiologist who is interested in dealing with childhood problems. You must measure the AP diameter of the pelvis, must measure the cortical thickness. How is the corticomedullary differentiation? Is there any associated medical renal disease? What is the echogenicity of the cortex? And what is the size of the kidney? All these things should be documented because you will come back for comparison. Then ask for measurements so you can compare later on. And ensure that the child has an empty bladder. Tell the radiologist, if the bladder is full, please do a repeat one once the child has passed urine. Because full bladder may cause the renal pelvis to dilate and there may be false positive diagnosis of a PUJ obstruction. Now, ultrasound is also very important investigation for follow-up after a pyeloplasty. And you will normally like to document how much is the residual dilatation and how much is the renal growth with passage of time. They sometimes tell you whether or not the pyeloplasty is successful. So, ultrasound becomes a very important investigation in follow-up, especially if the DTPA gives you a false interpretation of persistent obstruction. Now, in such situation, it is important that you do an ultrasound, and if you have done a an ultrasound soon after the operation to document the residual dilatation, then follow-up ultrasounds can tell you whether this dilatation is progressive or not. If it is not a progressive dilatation, then whatever may be the DTPA report, you will reassure the patient that the pyeloplasty is probably functioning and it's only a false interpretation on DTPA. So, as Dr. Nitin asked, antenatal ultrasound diagnosis is important. Remember, 2% of all antenatal scans detect dilated kidneys. How they pick up PUJ obstruction on antenatal scans is by seeing the renal pelvis dilatation. And remember again that of all antenatal diagnosis, 17% pertains to the kidneys. And out of these, at least half of them have upper tract dilatation, which can be termed as a PUJ obstruction. But again, remember that all antenatally detected hydronephrosis does not mean PUJ obstruction. As a matter of fact, 80% of antenatally detected hydronephrosis does not does not require surgery, and that is the importance. Actually, antenatal ultrasound has given us a radiological finding which is often misinterpreted as a pathological entity. So there is sort of an epidemic of neonatal hydronephrosis which is equated with PUJ obstruction. But it's very important to know that all antenatal hydronephrosis is not PUJ obstruction. It may be non-obstructive dilatation which has a natural history to disappear with passage of time. It's important to know how to identify those 20% of cases which will require surgery. But 80% don't require surgery. So during antenatal ultrasounds, there are certain things which are important. One of them is an antenatal history. How is the progression of hydronephrosis antenatally? At what stage the ultrasound scan was performed? Whether it was repeated? Most renal anomalies are picked up or can be picked up as early as 16 weeks. Usually a 20-week scan is performed and the ultrasoundologist picks up some problem in the kidney. Then it is imperative that the ultrasoundologist does a repeat ultrasound, say 4 to 8 weeks later, and then looks at the system again and sees whether or not there has been a change. So that will give you an antenatal history. And if you have measured the diameter of the pelvis, then up to 30 weeks of pregnancy, about 4 millimeter dilatation of the pelvis is considered normal. So it is considered abnormal only if it has exceeded 7 millimeters. And between 30 weeks to term, up to 10 mm dilatation of pelvis is considered as normal. So these measurements are important. It is not good to say or read a report like mild hydronephrosis or moderate hydronephrosis, severe hydronephrosis, because the definition of these things can vary from person to person. Now, once you know the antenatal history and you have counseled the parents and the patient has proceeded to term delivery, then postnatally you must do an ultrasound. And this is an important slide. This tells you the significance of taking down the measurements. Now, postnatal scan again has to measure the AP diameter. And AP diameter, if it is 10 millimeter or below, then it is normal. You need not worry about it. If it is 10 to 20 millimeters, it is borderline, but it becomes significant if it exceeds 20 mm. And after that, the chances that the child will require surgery go up and up. Say, for example, if the AP diameter of the pelvis is above 50 millimeter, then nearly 100% of them will require surgery. If it is about 40 millimeters, 80% of them will require surgery. So the degree of dilatation on postnatal scan is a direct evidence to suggest that which patient will require surgery and which patient will not require surgery. So this is an example of an ultrasound showing a dilated pelvis and then sudden cutoff. You can't see any ureteric dilatation. So this is a hydronephrosis because of PUJ obstruction. Now this is a typical DTPA. The report will come like this. Yes, we have a question.
In a given case of antenatal hydronephrosis, when do we perform the first ultrasound?
You mean postnatal?
Postnatally, when do we perform the first
Right.
ultrasound?
Now that will depend on how well the child is. Usually in a unilateral hydronephrosis antenatally diagnosed, the child is expected to be well at birth. And in that situation, we need not worry about performing the ultrasound soon after birth. As a matter of fact, we should allow the physiological adjustments that are taking place in the child's fluid milieu in the immediate postnatal period. Remember, there is a period of physiological hydremia in the child, and it requires about 72 hours for that to settle down. So let that happen, and you perform the first ultrasound postnatal on day 3 or day 4, not before that, because before that if you perform, the child has more water load and therefore a less dilated system may be misinterpreted as more dilated system. But this is providing the child is well, and the child is expected to be well with unilateral hydronephrosis. Okay, is that clear? So on the DTPA scan, this is what you will get a report about. So several frames have been taken here. It says 2 seconds per frame. So this is actually the vascular phase or flow phase. This shows the renal blood flow and how much of the blood is going to each kidney. And then you will have these frames. This is one frame, 1 minute per frame. This actually shows the excretion of the dye. Remember, DTPA is the same as IVP. So you tend to get the same information on DTPA as you would have gotten IVP. So the dye, the radioactive dye, gets concentrated in the urine. So it is transported across the tubules, then gets into the pelvis and gets concentrated in the pelvis. So what information you don't get on IVP and you get on DTPA is this, that you get a flow pattern. Then you can compare the differential function on each side. You can calculate how much of dye is getting concentrated on the right side, how much of it is getting concentrated on the left side, and then you can compare. Also, what you can study on DTPA is how well the dye is getting cleared from the kidney, or what is the drainage pattern, whether it is obstructive or non-obstructive. So, and that you can quantitate, in fact, on the DTPA scan. So here you can see that the dye is getting concentrated earlier on this side, and this is usually a posterior anterior view on the gamma camera. So unlike IVP, where this is right and this is left, here it's reversed. So this is the right side, this is the left side. Okay, and then you get a delayed film here, and delayed film you can see here the dye is still staying on this system but not here on this system. Okay, that means this has not drained well. And then you draw a time activity curve. So the activity of dye with time will rise in the kidney pelvis and then will fall as it will get cleared. Okay, so the typical curve will be it will go up and then fall down. But here on one side it is doing that nicely, on the other side it is going up slowly but then not as high as this one, and then staying there, not coming down. So this is an obstructive pattern of drainage. This is a normal drainage. Okay, and sometimes you have an in-between curve, equivocal, and in those situations it is good to give Lasix in between, furosemide, so that if the dilatation is non-obstructive, then with furosemide it will show drainage. Okay, so furosemide diuretic renography is done to differentiate between an obstructive dilatation and non-obstructive dilatation. So obstructive dilatation, even after giving Lasix, you will still have an obstructive pattern. The dye will not get cleared from the system. While on the other hand, if you have a non-obstructive dilatation, then with Lasix you will expect the dye to get cleared from the kidney. Okay, so that is how you differentiate between obstructive and non-obstructive dilatation. So this is the blown up view. So 2 hours, 4 hours, up to 4 hours, you see on this side the dye is not clearing. So this is an obstruction of the this side on the DTPA will be left side. So this is a left PUJ obstruction. And here you are. Further report, left kidney, GFR. Another thing you can contribute is you can calculate GFR from the DTPA study. So differential function, 27% of the overall renal function is contributed by left kidney, while 72% is contributed by the right kidney. Okay, and then you will get the impression, left side enlarged hydronephrotic kidney with moderately impaired parenchymal function with obstruction drainage pattern. So this is the information you get on DTPA. But there are several limitations of DTPA. DTPA is not handled very well by poorly functioning kidneys, and you can't perform them in immature kidney of a neonate. So you must wait for about 6 to 8 weeks before you can really get some useful information on DTPA. And sometimes total obstructed kidneys can show 0% function, even though they have a potential to recover. So you may misunderstand that, well, this kidney is not contributing anything, so let us remove it. So 0% on DTPA does not mean that you will remove the kidney. Sometimes when the bladder is full, you will get a false impression of PUJ. And the difference or the improvement in function after pyeloplasty is not very well appreciated on DTPA. And sometimes supranormal function can be reported with obstructive curves. And again, then unlike IVP, it does not give you any anatomical details. Remember that ultrasound and renal scintigraphy combined together, they can correctly identify PUJ obstruction only in about 75% of cases, not in all. And it's all because of fallacies of these investigations. Nothing is foolproof. Ultrasound is operator dependent, DTPA is computer dependent, and there are so many fallacies as I have listed. So therefore the accuracy of these two combined is only 75%. And that is why many people now have resorted back to using IVPs for diagnosis of PUJ obstruction. So on IVP, what are the indicators of PUJ obstruction? How can you diagnose PUJ on IVP? On IVP, there may be a sudden cutoff from the pelvis, no ureter seen in any film, and the calyceal anatomy will also change. Normal calyces are cup shaped. In obstruction, the cups are obliterated. In more obstruction or more severe obstruction, the cups can be club shaped or they can be blown up calyces. So no ureter seen in any film, sudden cutoff, and changed calyceal anatomy. These are the three cardinal